Hello, this is Dr. David Green, CEO of the Ohio Pain Network. Today's topic is what you need to know about epidural injections. An epidural injection is an outpatient procedure that involves the placement of steroid and numbing medicine into the epidural space. Epi means around, dura is the covering of the spinal cord. It's designed to relieve the pain from nerves that are getting pinched. The injection does not go into the spinal cord. It does not go into the nerve roots. It goes around them. What are the indications for this injection? Usually it's a herniated disc where a patient has experienced radiculopathy, such as a neck herniated disc, or sciatica, such as in a lumbar herniated disc. Spinal stenosis, which is where you have overgrowth of bone or soft tissue due to arthritis, and it starts pinching on some of the nerve roots as they try to get out from the spine. You may have degenerative disc disease with a disc bulge. That's actually what's shown here. So you have a disc bulge, and the bulge is pinching on a nerve root, and it's causing inflammation and pain. Okay? If you have a tear in this disc, that may also cause pain. Then a compression fracture can also lead to inflammation and pain in the surrounding area. What are the different types of epidural injections? There are 3 types. Let's go through them. Interlaminar is what you see here. So this is a lamina, this is a lamina, this is interlaminar. You see there's no bone here. There's a soft tissue covering, and just to be exact, it's called the ligamentum flavum. What the pain doctor does is put the needle through the ligamentum flavum, and once through, that's the epidural space. So that's where the steroid is put. Okay, that was the first epidural injection invented. That was back in the 1950s, still used today. Here's a transforaminal. So the needle's not put here in the interlaminar area. It's actually put out here. This is the newest type of epidural. See where this nerve root is coming out? That's called the foramen. That's the opening where the nerve root comes out. So the needle goes what's called transforaminal, and the steroid goes in here, and that's usually where the disc herniation and pinching is occurring. So it's a more exact placement. A caudal epidural is a different approach altogether. So this is the very, very bottom where the sacrum is. The needle goes through the sacral hiatus. There's a little opening here. A much larger volume of steroid and numbing medicine is injected, and gravity helps it migrate up into the lower lumbar areas. Okay, so if you have spinal stenosis at multiple levels and are getting nerves being pinched, this is great because it can actually treat multiple levels at the same time. How are they performed? Outpatient, about a 30-minute procedure. You can have IV sedation. It's not necessary. You can just have local numbing of the soft tissues. Usually modern pain doctors use a real-time image guidance called fluoroscopy, and that's a real-time x-ray. It shows where the needle is exactly. Some pain doctors will use ultrasound. That's also good. For interlaminar, the technique is called loss of resistance because the needle's going through the soft tissue that's called the ligamentum flavum. So it goes, and then you lose resistance as it gets to the end of it, and that's called the loss of resistance technique. Usually the pain doctor will inject some dye to make sure they're not in a blood vessel or in the spinal sac to make sure it's accurate, and then they'll put in the numbing and pain medicine. Patients go home the same day after about an hour. How well do they work? There have been dozens of studies looking at the effectiveness of epidural injections. Overall, some show 50%, but a lot of them show a 75 to 90% good to excellent results. Okay? A person may need a series of 3 injections over a 6-week period to get the most benefit. The numbing medicine works right away. The steroid may take 2 to 3 days to kick in, and then it may last for a few days to a few months. It's going to be a variety. What are the risks? The risks are very small, but they're real. Okay? There's a risk of infection, less than 1%. There's a risk of some bleeding. You should stop anti-inflammatory medications about a week before. There's a risk of an allergic reaction, possibly some side effects that are transient from the steroid. There's a risk of nerve injury. The biggest risk is that it may not work. Okay? The overall complication rate is well under 1%. Are they FDA approved? The answer is no. They're not FDA approved. This is not a bad thing. Medications are used all the time for off-label indications in this country. 40% of the time, okay? It's legal. It's often beneficial. Here's 3 quick examples. Neurontin is FDA approved as an anti-seizure medication, although it's used predominantly for nerve pain and for migraines, okay? It's not FDA approved for that. Lidoderm is FDA approved as a skin patch for shingles, but it's used off-label for back pain and other numbing needs. All right. Propranolol is an FDA approved hypertension medication. It's used off-label all the time for performance anxiety. So it doesn't really mean anything. The top non-operative pain management in Ohio is through the Ohio Pain Network. There are several clinics throughout the state, accepting over 50 insurances and providing over 25 treatment options with the board-certified, award-winning doctors. Visit us online today at ohiopainnetwork.com and then call us for more information and scheduling at 888-466-9898. I'm Dr. David Green with the Ohio Pain Network. Your pain stops here.